Hello everyone, my name is Rosette and I am Egyptian pharmacist. I'm talking from Egypt. Firstly, I'd like to thank everyone who invited me to participate in this national webinar, and a special thank to the professor Dr. Muhammad Wasiallah that gave me this impressive opportunity to be a speaker in this webinar. Also, I'd like to thank the Prasad Institute of Technology that gave me this beautiful chance to present a small lecture and presentation to my Indian colleagues in pharmacy. Today, I will discuss with you and present a short lecture, as I mentioned before, to differentiate between asthma and chronic obstructive pulmonary disorders and the importance of vaccination for those patients. And I'd like to mention that asthma and COPD are the major diseases, major pulmonary diseases all over the globe. So those topics are really important for anyone who work in a hospital, and anyone is a community, whether is a community pharmacist or clinical pharmacist. So I will close the camera now and check the recorder, and I'd like to thank Dr. Muhammad Wasiallah for his flexibility to record this session according to many issues. Okay, and we will wear our beautiful glasses. Give me 1 second, please, and we will go. Yes. Let me present myself to you firstly. My name is Rosette. I'm an Egyptian pharmacist, and I've graduated from the Pharmaceutical Sciences at Assyut University, Egypt since 2007. And from this time I became a registered community pharmacist in the Ministry of Health and Population in Egypt. After that, I decided to update my information and update my skills, so I decided to get an American certification, which is called Board Certified Pharmacotherapy Specialist since 2016. So from this time I became a clinical pharmacist. I had a beautiful opportunity to be a medical instructor because my colleagues and my tutors also invited me to be a medical instructor in their private centers, and I helped many colleagues with mentoring and teaching them how to answer the clinical cases, especially multiple choice questions in critical way. Then I tried to advance my skills, and I became a medical translator from the English language to the Arabic language. Also, I've awarded with an impressive opportunity to be a medical writer and write more than 400 multiple choice questions for the adult gerontology acute care nurse practitioner in the USA under supervision of an American doctor. Finally, there was a beautiful chance to be a marketer and market a healthcare app, and this application is specified for alternative medicine. I enjoyed too much for marketing this application, and this application is called Apple A Day RX. So I enjoyed too much with doing different jobs, and I had flexibility to do many different tasks. I have a good luck. Okay, let's start now about our objectives. The first thing, we will mention about the definition of both asthma and chronic obstructive pulmonary disease. we will discuss the symptoms and how to differentiate between asthma and COPD, how to adjust the patient, and how know the severity of the asthma and chronic obstructive pulmonary disease, how to assess the patient after the treatment, what is the treatment for those cases, and what is the importance of the vaccination, and what is the vaccines that will be needed for those patients. Firstly, we will take the definitions, simple definitions for asthma and chronic obstructive pulmonary disease. Firstly, definition of asthma. This is a chronic inflammatory disorder of the airways causing recurrent episodes of wheezing, breathlessness, cough, and chest tightness, particularly at night or early in the morning. And this is an important keyword for the asthmatic patient. When we discuss with the patient, we must ask him or her whether his cough in at night or early in the morning or throughout of the day. Also, during episodes, there's variable airway obstructions, often reversible spontaneously or with treatment. And this is another important keyword for the asthmatic patient. His obstruction is reversible. However, in chronic obstructive pulmonary disease is partially reversible, and we will see this in its definitions. The definition of chronic obstructive pulmonary disorder is a preventable and treatable syndrome of persistent limitation in expiratory airflow, and this is a combination between obstructive bronchiolitis and parenchymal destruction, which is called emphysema. So the airflow obstruction may be accompanied by airway hyperresponsiveness, and as I talked before, may not be fully reversible. So this is our simple definition for both treatment, and I hope that I cleared the situation. Okay, let's go about diagnosis in this short lecture because of our tight time. So I will not mention every point, but everything it will be in the PowerPoint for you, and you can ask me or contact me via my LinkedIn profile or via Gmail. Anyway, let's talk about diagnosis now and how to differentiate between asthma and chronic obstructive pulmonary disorders. Age of onset. We all know that patients younger than 12 years old can suffer from asthma. Infants can suffer from asthma, children, adults, elders, in any age, patient can suffer from asthma. However, chronic obstructive pulmonary disease, only the patient who are older than 40 years old can suffer from these disorders. Pattern of symptoms in asthma. There is a variation in symptoms over minutes, hours, or days. However, in chronic obstructive pulmonary disorders, persistence of symptoms despite treatment. There is persistence of symptoms despite treatment. This is a keyword. We can return to asthma, worse during the night or early morning. However, in chronic obstructive pulmonary disease, good and bad days, but always daily symptoms and exertional dyspnea. In asthma, another keyword, triggered by exercise, emotions, dusts, or exposure to allergens, and there is a massive types of allergens: wood, rubber, water, egg, some vegetables, some fruits. However, in chronic obstructive pulmonary disease, there is a chronic cough plus sputum. Okay, and this is unrelated to trigger. This is for Smokers. People who suffer from chronic obstructive pulmonary disorders are heavy smokers. Lung function between symptoms. In asthma, there is normal lung function. However, in chronic obstructive pulmonary disease, the function is abnormal. History, past history or family history. In asthma, there is previous diagnosis of asthma, there is family history of asthma or other allergic conditions like allergic rhinitis or eczema. However, in chronic obstructive pulmonary disorders, previous diagnosis of chronic obstructive pulmonary disorders, chronic bronchitis or emphysema. Also, there is another keyword, heavy exposure to a risk factor, tobacco smoke, biomass fuels. So, as I told you, people who suffer from COPD are heavy smokers. Time course of asthma. No worsening of symptoms over time. Symptoms vary either seasonally or from year to year. However, another keyword, symptoms slowly worsen over time. There is a progressive disease over years. In asthma, may improve spontaneously or have an immediate response to bronchodilators, whether long-acting bronchodilators or short-acting bronchodilators, and we will explain all those points in other slides, or with inhaled corticosteroids over weeks. However, another keyword, COPD hasn't fully response or has only limited relief with short-acting or rapid-acting bronchodilators. For chest radiograph, as I told you, lung function is normal, so there is no issues or difficulties or any other abnormal things in chest radiograph. However, in COPD, there is severe hyperinflation. Let's talk about asthma severity. There is 4 asthma severity: intermittent, mild, persistent, moderate, persistent, severe, persistent, and how differentiate between those things we must discuss with the patient and know frequency of symptoms and nighttime awakening, and how many times to use short-acting bronchodilators such as albuterol. Okay, in intermittent, frequency of symptoms less than 2 times per week, and nighttime awakening less than 2 times per month. All these things are keywords for clinical cases. SABA will be used less than 2 times per week. Mild persistent, frequency of symptoms will be more than 2 times per week. Nighttime awakening will be 3 or 4 times per month, and also using of SABA will be more than 2 times per week. For moderate persistent, symptoms will increase frequency of symptoms daily, nighttime awakening more than once weekly, but not nightly. Maybe 5 times, 6 times per month, 8 times per month, and using SABA will be daily. Also in severe persistent, a patient can't sleep, can't fall, can't walk. There's a frequency of symptoms throughout the day. He exerts effort to take up a simple breath and exert effort to expand his respiratory muscles. In nighttime awakening, often 7 times per week, this is regularly. So those patients always require administering in intensive care units. Using SABA will be several times per day. And we will talk about interference with normal activity, intermittent. The patient will not suffer from any limitation. He can do his daily routine. In mild persistence, there is a minor limitation. Moderate persistent, limitation will be increased, some limitations, and severe persistent will be extremely limited. As I mentioned before, this patient in bed. And I should define for you the forced expiratory volume and the forced expiratory volume 1 and FCV. Here is a brief definition for them. FEV1 is a volume of air exhaled forcibly in the first second of maximal expiration. And if VC is a maximum volume of air that can be exhaled after for expiration. The ratio is really important because this can differentiate between the normal patient and between the patient who suffer from obstructive disorders like asthma or COPD. So in FEV1, the normal patient will be more than 80%, okay? And for ratio, the normal patient will be usually between 75% to 80% in adults. And as I told you, it will be decreased, will be less than 70% for a patient who suffer from obstructive disorders or obstructive diseases. Let's go to our presentation. Let's talk about exacerbation requiring oral steroids for intermittent. No more than one exacerbation per year. For mild or moderate or severe persistent will be more than 2 times per year. Okay? I will stress on the adults who are older than 12 because of the time. The recommended step for initiating treatment is really important for us, and this is differ according to age. So intermittent, the patient will take, or the physician provide him step 1. Mild persistent, the patient will take step 2. Moderate persistent, step 3 plus short course of oral steroids. So in moderate, he needs a short course of oral steroids. In severe persistent, differ according to the age. For adults older than 12, the patient can use step 4 or 5 plus short course of oral steroids. For patients who are between 5 to 11, only step 3 or 4 plus short course of oral steroids, and this is because there is a serious adverse effect on children with treatment of step 5. For children and infants neonates from 0 to 4, only step 3, and we can't make a step up for them plus short course of oral steroids. So in moderate persistent and severe persistent, we must use short course of oral steroids, and the treatment of severe persistent is differ according to the age. The patient is diagnosed as asthma, and we give him a treatment. After that, what we will do? We should assess this patient. So we should monitor this patient after his treatment, whether his symptoms is well controlled, not well controlled, or very poorly controlled. So in well controlled, his symptoms will be less than 2 times per week. At nighttime awakening will be less than 2 times per month. there is no interference in normal activity, and using SABA will be less than 2 times per day. Okay, in not well controlled, this is logically symptoms will be more than 2 times per week, and nighttime awakening will be more than 2 times per week also. Interferes with normal activity, some limitations, logically, this is logic, and using SABA more than 2 times per week. Very poorly controlled symptoms, usually throughout of the day. Nighttime awakening every day, more than 4 times per week. Extremely limited, and using SABA several times per day. Okay, now we will talk about exacerbations requiring oral steroids for well-controlled, no more than 1 time per year. Well-controlled patient. This is logic. Not well-controlled and very poorly controlled, logically exacerbation will be increased more than 2 times per year. Recommended action for treatment. This is too important for us. For well-controlled, logically, a patient is well-controlled, so we can maintain in current steps, and we can't make step up, whether or make step down, but we should make a regular follow-up every 1 to 6 months. And if we find the patient is well controlled more than 3 months, so we can make step down. A simple example: patient has a moderate persistent asthma, and he takes step 3. So he, after treatment, he became a well controlled. Okay, and after assessment of his symptoms and monitoring him, following up after 6 months, so his symptoms are well controlled. So what we can do for him? We should decrease and make step down. So we advise him to take step 2. In not well controlled, logically, we will increase the steps of his treatment, but only 1 step, and re-evaluate him in 2 to 6 weeks. Very poorly controlled. This patient is extremely limited. And logically, will we increase and make a step up, not more than, more than 1 step, and we will evaluate him in 2 weeks. Let's discuss and talk what is meaning of step 1 or 2 or 3, or what are you talking about? So this table will explain everything. As I mentioned before, I will stress on adults who are older than 12. Okay? For step 1, preferred treatment: low dose of inhaled corticosteroids plus formoterol. Formoterol is long-acting bronchodilators as needed. So we can use LABA as needed and as scheduled. As scheduled, the physician prescribes it for you, LABA, and he advises you to take this medication twice daily. So this is scheduled, as scheduled. However, as needed is if the patient found himself there is obstruction, and his low dose of inhaled corticosteroids make partial relief, so he can take formoterol. Okay, this is as needed. For step 2, for adults older than 12, preferred low dose inhaled corticosteroids or low dose inhaled corticosteroid plus formoterol as needed. So there's no difference between step 1 and step 2. The difference in step 2, in patients who are between 6 to 11, preferred for them low dose inhaled corticosteroids, and the alternative is leukotriene modifiers. Okay, also for patients who are from 0 to 4, preferred for them low dose of inhaled corticosteroids. However, in step 1, we can't treat those patients. No daily control. This means we can't make them take inhaled corticosteroids or formoterol. Okay. Step 3, for adults more than 12, preferred, we will increase the dose. As I told you before, in step 1 and step 2, LABA was as needed. Now, from this step, LABA will be scheduled as scheduled. So, in step 3, low dose of inhaled corticosteroids plus LABA as scheduled. And or the alternative treatment, medium dose of inhaled corticosteroids only, without LABA. Or low dose of inhaled corticosteroids plus leukotriene modifiers if the patient suffers from adverse effect from LABA. Okay. For step 4, we will increase the dose of inhaled corticosteroids, medium dose of inhaled corticosteroids plus LABA. The alternative, high dose of inhaled corticosteroids plus tiotropium, and we can add tiotropium for a patient who has many exacerbations in 1 year. Okay. In step 5, we will increase the dose of inhaled corticosteroids. As we see, we only increase the dose of inhaled corticosteroids. In step 5, high dose of inhaled corticosteroids plus LABA plus tiotropium, because this patient has a severe case. So there is logically there is a history of exacerbation, so we can add on tiotropium plus omalizumab for allergic asthma. What is the meaning of allergic asthma? Allergic asthma, this is an increasing of eosinophilia in his blood, maybe more than 300 cells, or using IL-5 antagonist for eosinophilic asthma. Okay, for patients who are from 5 to 11, refer to phenotypic assessment. The alternative, add on IL-5 antagonist or low dose oral corticosteroids. For patients who are younger than 5, not appropriate for them to be treated with step 5, as I mentioned before in the past slides. After that, we should manage the patient in hospital or in intensive care and know how to treat the patient who suffer from exacerbations. But as I mentioned before, there is a short limited time in our lecture, so I can't discuss with you those points. Let's talk about chronic obstructive pulmonary disease. What is the diagnosis? Smoking history of more than 55 back years, wheezing on auscultation. Patient's self-report of wheezing. The patient will will hear his wheezing. Assessment. According to GOLD guidelines, there is 4 assessments: GOLD 1, 2, 3, 4. GOLD 1, there is a mild if EV1, and if EV1 is greater than 80% of productive. In GOLD 2, this is a moderate case. If EV1 between 50 to 79% of productive. GOLD 3, severe, if EV1 between 30 to 49% of productive. GOLD 4, very severe, if EV1 less than 30 of productive. All those things are important keywords for any clinical case or any multiple choice question for COPD. Okay. As I mentioned before, how to assess the patient who suffer from chronic obstructive pulmonary disease and which therapy is suitable for them. We talked about different GOLD guidelines, and we will talk about how to select the appropriate therapy for those patients. So we have 4 groups: Group A, B, C, D. Patient with a stable COPD. Group A. What is the meaning of Group A? Group A, this patient didn't suffer from any hospitalizations in the past 1 year, and less than 1 time observation in the past year. His symptoms is few, and because of his symptoms is few, so the CAT score is less than 10. So the recommended first choice for him, bronchodilators, whether short or long-acting bronchodilators. Recommended treatment intensification. This step will be taken if the first choice is failed. So the GOLD guidelines said that for Group A, we should continue or discontinue or try alternative class of bronchodilators. What is the meaning of this topic? A patient with Group A, and the physician diagnosed him as Group A. He gave him albuterol. He suffered a lot with this treatment, and he wasn't well controlled. So the patient, the physician will advise him to give him another treatment like LABA for material. Okay, for Group B, the patient has less than 1 exacerbation in the past year. He didn't go to any hospitals, and there is many symptoms. Okay, and this is because so CAT score would be more than 10. And how to differentiate between A and B? The symptoms and CAT score, and both of them less than 1 time exacerbation and no need for hospitalization. Okay, recommended first step, LABA or LAMA. What is the meaning of LAMA? LAMA, long-acting antimuscarinic agents, labtitropium. Okay, and if this treatment is failed, so recommended treatment intensification, combination between LABA and LAMA. For Group C, we should concentrate in this point. In Group C, there is more than 2 times exacerbation in the past year, and more than 1 time hospitalization for COPD exacerbation. However, his symptoms is few, so CAT score is less than 10. Okay, sorry. Okay, so the recommended first treatment is LAMA. If this failed, there is a combination between LAMA and LABA, okay, or LABA plus inhaled corticosteroids. When we can use inhaled corticosteroids, we can use this step if there is eosinophils in his blood and is more than or higher than 300 cells per mcl. Okay. In group D, the patient suffered from more than 2 times observations in the past year, and he went to hospital more than 1 time. Also, there is many symptoms, so the CAT score more than 10. And how to differentiate between C and D by CAT score? In C, CAT score is less than 10, but in D, CAT score is higher than 10. How to differentiate between A and C? Exacerbations and hospitalization. In A, no hospitalization, from 0 to 1 exacerbation in the year, per year, but in C, there is more than 2 times 2 exacerbations, and he needed to go to the hospital to treat the exacerbation. Okay, recommended first choice for D, LAMA or LAMA plus LABA, and we can add LAMA and LABA if this patient is highly symptomatic, and this means CAT score is higher than 12, or use LABA and inhaled corticosteroids if his eosinophils is more than 300. Recommended treatment intensification: LAMA plus LABA plus inhaled corticosteroids if eosinophil is greater than 100 cells, and add roflumast. When we add roflumast, when the eosinophil less than 100. So we can add inhaled corticosteroid if eosinophil is higher than 100. However, we can add roflumast if eosinophil is less than 100. And we can add azithromycin if eosinophil is less than 100 cell, also still and formal smoker. Okay, let's talk about the vaccination. Vaccination is too important for patients who suffer from pulmonary disease and from any disorder, and for healthy people also. So the two important vaccination for those people who suffer from pulmonary disorders are influenza vaccine and pneumococcal vaccination. According to CDC recommendation, there are many types of influenza vaccine. Live attenuated vaccine, inactivated trivalent vaccine, quadrivalent inactivated influenza vaccine, recombinant influenza vaccine. Okay. Live activated influenza vaccine is contraindicated for pregnancy and for people who suffer from immunocompromised diseases. Because of influenza vaccine is produced from egg protein. So some people have egg allergy from this vaccine. If the patient has egg allergy, what we can recommend for him? If the allergy is only hives, so recombinant influenza vaccine and inactivated influenza vaccine are recommended for him. If the patient his egg allergy is severe, like angioedema, so it's recommended for him recombinant influenza vaccine, and there is supervision for the first hour or the first 30 minutes after the vaccination. People who suffer from Guillain-Barré syndrome is contraindicated for them using influenza vaccine. Let's talk about pneumococcal vaccination. All people who are older than 65 years old and suffer from asthma or COPD should take pneumococcal vaccine 13 should be administered firstly, and then after 1 year should be administered polysaccharide pneumococcal vaccine 23. Okay, and there is a part between them at least 1 year. For people who are in age from 19 to 64 with chronic medical condition like pulmonary condition, coronary vascular disease, smoking patient, alcoholism, liver disease, and the only exception is patients who suffer from hypertension. They should take 1 dose of polysaccharide pneumococcal vaccine 23. For patients who are between 19 and 64 years with a immunocompromising condition, there is 1 dose of polysaccharide, pneumococcal vaccine 30, followed by 1 dose polysaccharide pneumococcal 23, at least between them 8 weeks. And after 5 years, the patient should be administered with another dose of polysaccharide pneumococcal vaccine 23. Okay, let's talk about clinical case for asthma. We have a patient, woman, suffer from cough and wheezing twice weekly. Okay, it's cough or hair cough twice weekly, and she wake up at night 3 times per day. As we mentioned before, mild persistent is diagnosed when there is a nighttime awakening more than 2 times per month. Okay, so from this case will be mild persistent. Okay, she has never been given a diagnosis of asthma and hasn't been to a physician. She says in years she uses her roommate's albuterol inhaler, but having recently run out of refills, she today revealed FEV1 92% of reductive. According to the NAEPP guidelines, what's the best classification? As we told, this patient is mild persistent. Let's go to the clinical case of COPD. Okay, a patient, 62 patient, man diagnosed with COPD. Spirometry reveal a ratio if EV1 if VC 60% of protected, and there is yes, he reports walking more slowly than others because of shortness of breath and having to stop to catch his breath every so often when walking on level ground. Okay, his score MMRC is 2 and he had one exacerbation. Okay, uh, he didn't require hospitalization. Yes. What is the best appropriate patient group classification for him according to guideline? Okay, he has minor limitation. His score in MRC is 2. Okay, he has only one exacerbation and didn't require hospitalization. So we will think in answer A, gold 1, group A, or answer B, gold 2, group B. Here is the score is 2 in MMRC. So there are many symptoms. So we will choose answer B. If the score is less than 2, so we can choose answer A. So the appropriate patient group classification for this patient is go to group P. Okay? Yes, as we mentioned before, answer is B. You can read the rational answer to know more explanation for this case. Clinical case for vaccination. 71 years old woman with COPD is taking tiotropium, and she received influenza vaccine last October. Yes, her last TD vaccine was at age 65, and her PPSV 23 was given at age 60. She hasn't yet received the zoster vaccine, but she had an episode of severe zoster infection 5 years ago. Okay, which is the most appropriate choice of vaccine for the patient? October internal medicine clinic appointment. As we told before, influenza is required yearly, so this patient needs influenza. Also, this patient has chronic obstructive pulmonary disease and older than 65, so she needed a dose of pneumonia vaccine 30 plus polysaccharide pneumococcal polysaccharide vaccine 23. Okay, so until now answer B is appropriate. Let's see the other information in this case. The clinical case mentions that this patient didn't receive zoster vaccine. Okay, however, she had an episode of severe zoster infection in the past 5 years. In CDC recommendation, they advised and recommended that patients who are older than 65 years ago should take zoster vaccination whether she takes the infection or not. So zoster vaccine will be administered for this patient. So we can talk or see answer C. Okay. This patient, her last TD was at age 65. And as I remember, TD is administered every 10 years. Every patient older than 65 should take dose of TDAP, okay? And this is alternative vaccine for TD. So the best answer for this tricky question, I always prefer those tricky questions too much, and I love manipulate with ideas when I write any clinical case or any multiple choice question. So the best answer for this case is D. Here is the explanation, okay? And this is the final thing on our lecture, and I hope that I explained many things and many informations, and I will tell you thank you, and you can talk with me in any time and contact me via my Gmail or my LinkedIn profile. I will be happy to give my recommendation and give my advice and my explanation to everyone for you. So, bye bye for now.